Pediatric Emergencies Part 9. In this section, we're going to discuss child abuse and neglect, along with abuse mimics, sudden infant death syndrome, brief resolved unexplained event, also known as apparent life-threatening event, and we're also going to discuss children with special healthcare needs. Child abuse and neglect. Child abuse is any improper or excessive action that injures or otherwise harms a child or infant. It includes physical, sexual, and emotional abuse as well as neglect. In the United States, a report of child abuse is made every 10 seconds. In 2014, state agencies identified an estimated 1,580 children who died as a result of abuse and neglect, between 4 and 5 children per day. More than 70% of the children who died as a result of child abuse or neglect were 2 years of age or younger. More than 80% were not yet old enough for kindergarten. Around 80% of child maltreatment fatalities involve at least one parent as a perpetrator. There's several different types of abuse that we're going to talk about. Physical abuse, which is inflicting injury to a child. Sexual abuse, an adult engaging in sexual activity with a child, ranging from inappropriate touching to intercourse. Emotional abuse and child neglect, often difficult to identify, but this may go unreported. And neglect, which is refusal or failure on the part of the caregiver to provide life necessities. Emotional abuse can be defined as lack of emotional support by the caregiver. Also, abandonment. This occurs when a parent or guardian physically leaves a child without regard to the child's health, safety, or welfare. Abandoned children, also called foundlings, may be found in a home where the parents or caregivers have left them without appropriate supervision, or may be dropped off in a location to be found by someone else. Parents have relinquished consent authority, and EMS providers should render care without written or verbal consent. There's safe haven laws which allow the parent to leave a child without fear of legal implications. The children become wards of the state once they're dropped off. Children may be left unharmed by caregivers at the following locations: police stations, firehouses, hospitals, and specialized infant boxes. All 50 states have passed safe haven laws, but details vary from state to state. Keep the possibility of abuse in mind with injured children. Information you gather from seeing size up in interviews may prove invaluable. Act on any suspicions of abuse. Child abuse involves a pattern of behavior. A child who is abused once is likely to be abused again, possibly fatal. Risk factors for abuse. There are certain risk factors that make abuse more likely. This includes younger children, children who require extra attention, such as a child that is handicapped or has a chronic illness or other developmental problems. Child abuse occurs in all socioeconomic levels, but it is more prevalent in lower socioeconomic status. Divorce, financial problems, and illness, drug and alcohol abuse, and domestic violence in the home. If you suspect abuse, trust your instincts. Look for red flags that should suggest maltreatment. When you're called to the home of an injured child and suspect abuse, please trust your instincts. There's a mnemonic that is shown here on table 43-25, child abuse. C, consistency of the injury with a child's developmental age. H, history inconsistent with injury. I, inappropriate parental concerns. L, lack of supervision. D, delay in seeking care. A, affect of the parent or caregiver and the child in relation to the caregiver. B, bruises of varying ages. U, unusual injury patterns. S, suspicious circumstances. And E, environmental clues. Remember this, to recognize abuse, you first have to suspect it. Carefully document what you see. It's difficult, but you've got to remember it's important to remain impartial. Your number one priority is the care and the safety of that child. Record what you see and hear in a detailed incident report, but do not editorialize. Include notes about the child's environment, condition of home, and interactions among caregivers, children and EMS crew. Record concerning comments verbatim and who made them and when. In all states, pre-hospital personnel are mandated reporters. This means that you have a legal obligation to report suspicion of abuse to child protective services and law enforcement. Failure to report may be a crime. Reporting is done in conjunction with emergency physicians, social workers, and child protection teams at the emergency department. If you suspect abuse, involve police early to secure the scene. In cases where death occurs, the medical examiner will investigate the cause of death. Notify of any death if the child is not being transported to the ED. Approach ED staff with concerns, but not the caregiver. Do not confront the caregiver. Be aware of local regulations. You may have a legal and an ethical obligation to report to your local child protective services. The primary objective of child protective services should be to ensure children's safety within their families. The scene can be emotional. You got to focus on your trauma assessment and the management on the child's safety. Again, do not let emotions get in your way. Do not perform knee-jerk reactions. Be sure you're calm and collected because that child is depending on you. Be alert for a history that is inconsistent with the clinical picture. Look for bruises that are in different stages of healing. Also, bruises that are in concerning locations. Check the skin while looking for bruises. Active toddlers often have bruises on their shins, but rarely on their backs or buttocks. Bruises in identifiable patterns are rarely incurred accidentally. Belt buckles, loop cords, or straight lines. And use the child abuse mnemonic that we just talked about when you obtain additional history. Ask yourself, does the caregiver's explanation make sense? Could this child produce this bruise or injury through normal activities? Certain mimics of abuse can be difficult to distinguish from abuse. These are some normal skin findings. Mongolian spots, birthmarks that are generally found on the lower back and buttocks of children of Asian or African American descent. These may be mistaken for bruises because of their unique bluish coloring. Medical conditions can also mimic bruises when the child is experiencing purpura or petechial rashes. Purpura is seen in meningitis. Petechiae may be seen in meningitis, also of idiopathic thrombocytopenic purpura and leukemia. Or exposure to the sun can cause reactions with certain medications or fruits that the child may ingest. Certain cultural customs that can mimic child abuse. Coining and cupping is a traditional Asian practice, often used to treat fever. The markings can be impressive and very bold, but this practice is not harmful. Sudden infant death syndrome, or SIDS, is the sudden death of an infant younger than 1 year, and it occurs suddenly and unexpectedly, the cause of which is not immediately obvious before the investigation. Most SIDS are one of three types: sudden infant death syndrome, unknown cause, or accidental suffocation and strangulation in the bed. SIDS is formerly known as crib death. The sudden death of an infant younger than 1 year that cannot be explained after a thorough investigation is conducted, including a complete autopsy, examination of the death scene, and a review of the clinical history. About 1,600 infants died of SIDS in 2015. SIDS is the leading cause of death among infants 1 to 12 years old. Unknown cause, the sudden death of an infant younger than 1 year may remain undetermined because one or more parts of the investigation was not completed. In accidental suffocation and strangulation in the bed, the sudden death of an infant younger than 1 year can happen because of suffocation by soft bedding or overlay or wedging or entrapment. And this is going to be when an infant is wedged between two objects, such as a mattress and the wall. Or strangulation, when an infant's head and neck become caught between crib and railings. This is devastating to families and EMS crew who responds to the calls. In the assessment and management of SIDS, you need to be alert to other potential causes of death. Also remember the decision to start or stop resuscitative efforts can be difficult, and this is guided by local protocols. You've also got to keep your head about you. A thorough scene size up and history are important. The typical scenario for a SIDS call involves a healthy infant put down for a nap and is later found dead in the bed. On arrival of EMS, the baby will be lifeless and, depending on discovery time, may have rigor mortis and dependent lividity. Frothy or blood-tinged fluid in the mouth or nose or on the bedding is often typical. Be alert for clues such as death or clues. Be alert for clues to other potential causes of death such as trauma, suffocation, or maltreatment. Decision to start resuscitative efforts or to stop CPR that was started by first responders or family members can be very difficult. A brief, resolved, unexplained event, formerly known as an apparent life-threatening event, is an episode during which an infant becomes pale or cyanotic, chokes, gags, or has an apneic spell, or loses muscle tone. It is very dramatic and frightening to the caregivers who frequently promptly call 911. Causes may include benign and or serious diagnoses. Benign, a brief episode of laryngospasm during feedings or gastroesophageal reflux. Or serious, sepsis, congenital heart disease, and seizures. Once thought of as existing along the spectrum with SIDS, but recent evidence demonstrates that they are not related. It's common to find a distraught caregiver and a well-appearing baby. You should provide life support with signs of cardiorespiratory compromise or altered mental status, and transport all infants with a history of brief, resolved, unexplained events. Children with special health care needs. Children with special health care needs include those with physical, developmental, and learning disabilities. There's a broad range of causes, including premature birth, traumatic brain injury, congenital anatomic abnormalities, and acquired illnesses. Advances in technology and drugs have enabled an increasing number of children with disabilities to receive care in the community. This leads to a corresponding increase in EMS calls for this population. There's also a subset of children with special health care needs that may require your assistance called technology-assisted children. You should familiarize yourself with the types of medical technology that you may encounter and have to troubleshoot. A tracheostomy is a surgical creation of a stoma through which a tracheostomy tube can be placed for long-term ventilatory needs. Might be needed for a variety of reasons, including long-term ventilator support or chronic lung disease, inability to protect the airway due to neurologic impairment, or congenital airway anomaly leading to airway obstruction. Caregivers are a source of valuable information on all of these types of devices. The most common problem is obstruction of the tube with secretions, and if not treated could result in respiratory distress or failure. Tube displacement is another potential problem. With respiratory distress, assess tube position and suction the tube. If the child is using a home ventilator, disconnect the circuit and provide bag mask ventilation. And if the child does not improve or is cyanotic or in severe distress, you may need to remove and replace the tube, preferably using a tube of the same diameter and length. Confirm tube position as you would with an ET tube. A small ET tube can be inserted through the tracheostomy so that a standard oral ET intubation can be performed. Make sure the ET tube comes to rest below the level of the tracheostomy, or cover the tracheostomy and ventilate the patient with a bag mask device. Gastrostomy tubes or G-tubes, these are surgically placed directly into the stomach and they provide nutrition or medications. Some children depend on the G-tube for all of their nutrition. Problems such as obstruction, dislodgement, or leakage of the G-tube are not uncommon, but rarely represent an emergency, and most of the time the caregiver or the parent is well trained in these situations, and so typically you will not be called for minor issues. Central venous catheters. Central venous catheters may be inserted for long-term IV access for medications or nutrition. These can be PICC lines, these can be Broviac lines, these can be implanted ports. One big issue with central line or central venous catheters is going to be infection. And for the paramedic, the only time that we would access this is in a resuscitative situation. Ventricular shunts are inserted to drain excessive fluid from the brain. Remember, there's two types of ventricular shunts. You have the kind that drains from the ventricle of the brain into the abdomen, and also the kind that drains from the ventricle of the brain into the right atria. Issues with ventricular shunts could include obstructions and infections, and these will be medical emergencies, oftentimes with acute changes in status of the patient. When assessing and managing children with special healthcare needs, you should follow standard pediatric assessment sequence. Ask questions to establish baseline neurologic function and physiologic status. Meet the child at his or her developmental level, and work with the parents to restore the child to his or her own physiologic baseline. This requires collaboration with caregivers to determine what is normal for the child and management strategies that have been successful in the past. Transport to the child's medical home. If this is not possible, take along any medical records and assistive devices. Most important, take the caregiver. An ounce of prevention. Emergency care for children involves a team approach by healthcare professionals in the community and in the ED. The paramedic's role in prevention is not always highlighted, but can have a significant impact on public health by running a code or controlling an airway. To be an effective child safety advocate, you must be knowledgeable about local and national prevention programs. There's several different programs. Emergency Medical Services for Children is an example, which is a federally funded program created more than 25 years ago to reduce child disability and death due to severe illness and injury. Works with local communities and hospitals to improve care in and out of the ED. Works with existing EMS systems to improve the quality of emergency care as well. It helps develop pediatric-specific protocols and procedures and child-appropriate equipment for ambulances and emergency departments. Supports training EMTs, paramedics, and other emergency care providers in pediatric-specific emergency care. This concludes Part 9 of Pediatric Emergencies. If you have any questions, please reach out, Nick Ray at suscc.edu.